All right, we'll get started. We're going to cover today, we're going to start with chapter 14, knock it out. And the way it's the class is kind of laid out, we've got 1 through 7 was test 1, and 8 through 14 is going to be test 2. So we'll be finishing up what's going to be on test 2. We'll talk a little bit more about that when we get done. So let me share the screen to that. I'll try the slideshow. Hopefully it works on there. So today, what we're talking about is pain management as far as our clients and patients that we work with. And as we all know, a lot of the clients that are, eligible and in need of recreation therapy, are with us because of pain. And several of your videos that you did had to do with your client having pain in a specific area or coming back from, an injury. So pain is definitely something that we need to be, versed in as a recreation therapist. So we're going to define it, identify the 3 components used to classify it. There's different types of pain, and we'll talk about those, and there's barriers to effective pain management. We'll talk about that also. We'll talk about specifically pain management in children and elderly patients because they are the, honestly, the kind of middle age are the most commonsensical about pain and pain management, and they're already kind of doing things that they know they should do. Youth don't know to do it. A lot of times elderly just are kind of slacking on what they need to be doing. That's kind of what's happening there. And then we'll talk about some general guidelines and some treatment options as far as pain. So not to just read this stuff to you, but it's good information as far as when we're talking about pain. It's an unpleasant sensory and emotional experience arising from actual or potential tissue damage or described in terms of such damage. That's one. Or a subjective experience reflecting a dynamic interaction between sensory, affective, motivational, and cognitive systems. So what does that tell us? That pain is not just, I hit my thumb with a hammer, it hurts right here. You can have that physical pain in a specific spot, or you can have pain that is also, tied into other sensory areas. A lot of times it affects your motivations. Pain has a lot of areas where it affects us, not just at the specific pain site. It's like we talked about, I think it was in this class last time, my back was really hurt one time. I couldn't do much. I was struggling with what I was doing, and I found myself feeling depressed because I couldn't do anything I wanted to do. And that depression, to me, is a form of pain coming from an actual physical pain. So they tie in together. So know that your cognitive system and your affect is basically like your mood and what you give off. If somebody has a flat affect, they are just zombie flat face. If someone is looking really upset, they, have a sad affect. So it kind of has to do with your mood, and that's all affected as well from pain. So we need to realize that just because we may be treating someone's toe that is injured, doing some things that could help with a hurt ankle, that they may have some other cognitive sides of it that may be holding them back from feeling better also. So we need to kind of address, and that's the thing about recreation therapy that I really like, is that we do address, when done properly, those areas too, not just fixing the hurt spot, for lack of a better way to put it. So classifying pain, These are questions that you could ask. What's the duration of the pain? How long has it been going on? If it's something that comes and goes, how long does it usually last? Source, do you know what caused this to start, the pain to begin? Some people do and some people don't. If I'm not mistaken, probably the second worst that my back has ever been, I had no idea what happened to it. All I could think of was now this is ridiculous right here. I reached up to get a box of cereal off of a top shelf. Up here, box of cereal, weighs like less than a pound, okay? I'm talking about I couldn't get up out of bed by myself for like 3 days. Like, that was some serious cereal, apparently. I don't know. But sometimes people don't really know the source. I'm going to say that wasn't it. It was just ready to go, and all of a sudden something slipped in there, and it had nothing to do with that. But that was the only thing that I did prior to it that I could even attribute to it. So we want to find out what the source is. If someone got burned, they'll tell us, well, I've got this from being burned by this. I was cooking. So they may be a little traumatized by hot grease. Think about someone who is not you or I, okay? But think about a developmentally disabled client, participant who got a burn from being around something being fried, let's just say, okay? They got grease spilled on them somehow. They went in the kitchen when they weren't supposed to and grabbed the pan and spilled it. Somebody would get in trouble for that, for letting that happen. But anyway, let's say that happened, and then y'all were gonna go on a trip and say, all right, we're gonna go to Hibachi tonight for a special trip. We're talking about a developmentally delayed individual who just had a burn from something that was making a sound. They're probably not going to be able to tell you this, but knowing that source and what caused their pain is going to keep you from taking them to a hibachi restaurant and having them freak out when they hear that sizzle or see that fire come up off of the griddle. I mean, kind of over the top example, but it's very real world scenario, of why we need to know a lot of times where the source is. Transmission, does the pain, move from one spot to another? Are you hurt here and it hurts also down in your elbow? Things like that. So a lot of times we need to know that I have a deal with that in my shoulder right now. And I think it's from all the golf that I played through the years. I still haven't gone to the doctor. I need to, but it's definitely shoulder pain, but it goes all the way down below my elbow too. And like this movement right here is killer to me. I don't know whether it's like rotator cuff or what. I might need to get Miss Martin here to give me a empty can test, I think is what it's called, for rotator cuff, if I recall. But we need to know if they have like referred pain in other areas too, rather, on top of just the obvious pain that they tell us about. So the different types of pain, and this is good knowledge to know, and this is good like for you guys that are in the assessment class. When you do little write-ups about things that are going on with the patients, these are good words to remember and use. Patient exhibits acute pain. That's a good word. It means that it lasts 3 to 5 days. There's a specific cause. So acute, that is kind of short term. Chronic is prolonged and persistent. It's going to last generally 3 or more months. I wouldn't think that it would need to last 3 or more months to be counted as chronic, but that's what they have as the information here. Recurring lasts for a period of time, goes away and comes back. Procedure-related pain, okay, C-section, let's say. Surgery of any sort is going to give you some sort of discomfort for the most part. You know, I had gallbladder surgery. They went in basically through my belly button. It was not bad. However, the one place that hurt me was the cut, like where they cut right here over my belly button to go in. I had 3 or 4 other little like dots where they went in too. I couldn't even feel those. But for 3 or 4 days, if I stood up straight, it pulled on that spot down there. So I'm walking around like not wanting my belly to be straight because it was going to give me procedure-related pain. And then obviously pain associated with terminal illness. Now, that is a group that, yes, there is some recreation therapy that goes with this group. It is not a group that I think I could work with on a, you know, like a hospice or something like that. It's not something I could do because it would break my heart every time one of them passed. You know, it would just be the same thing over and over. It would not work for me. Some people have the compassion, the empathy, and the general makeup that they're made for that. And there's people that thrive in that environment and they can handle it and realize that they're helping the family and that they're helping the individual, and those people need it too. But, you know, pain associated with terminal illness, especially once you get to end stage, they basically just try to make them as comfortable as possible through medication and things like that. That would have nothing to do with us as a recreation therapist. So what are some barriers in relation to pain management? There's problems that are related to healthcare professionals, and it's just the fact that some healthcare professionals, yes, this thing, it is brighter today, I promise. I don't know if y'all will agree or not, but it is, because I can see it a whole lot better when I turn around. Problems come from inadequate knowledge, inadequate competence, and poor assessments. You know, we talk about in the assessment course, which happens right after this one, that some of y'all are in, some of you are not. But, you know, we know API, and we know that assessment is first, and it's first for a reason, and it needs to be done right, and it needs to be accurate. Because if it's not, if you don't have an accurate assessment, then you're going to end up doing the wrong things, or at least not as good of a job as you could do if you had a proper assessment. Some professionals don't, you know, they try to take on a task or a client that they've never worked with this client before. And rather than reaching out or saying, hey, Tia, you've worked with clients with cerebral palsy before, you know, what are some good ideas? You know, what can we do? Or would you like to take on this particular client and I can take one of yours? You know, you can do things like that. Rather than doing that, they'll just take on the client and not really have the background knowledge in working with that specific population. Thus, they're not going to be getting the best care and the best pain management help from us because of just lack of knowledge. That happens. You know, that's where things like CTRS certification, other certifications and things like that come into play, is because what they say, you know, what that certification says is that you have the competence to practice as a professional. Just because you have that and it says that you have the confidence, you still have to realize if you want to do the best job you can do, that you have certain areas that you have more knowledge in than others, and certain areas you're going to be better in than others. Now, there's 2 things you can do. You can kind of try to refer those patients to other people if it's a possibility. You can ask a lot of questions. You can do research and reading on your own to expand your repertoire with that group, which is that's really what you need to do. because you might not always be in a situation where you can just kind of pass the buck. Here you go. You take this one. I don't know anything about people with Prader-Willi syndrome. You know, you may not be able to do that. So that self-growth, you know, time where you try to make yourself better and we should all want to do that anyway. Some other problems: concern over patient addiction and regulation of controlled substances. What are a lot of people dependent on and addicted to that has to do with this chapter? Yeah, pain medicine is huge. The amount of people who are, you know, addicted to hydrocodone and oxycodone and all these things with codones and Percocets and all these things, man, they crush them up and snort them and everything else. Now, those are for, you know, pain reduction. You got people that you need to get them off of what they're doing, you know, and it all generally when somebody starts into this cycle of addiction that has to do with pain medicine and things like that, it's because it starts because they have an injury, because they had an issue where, you know, they had their wisdom teeth pulled, and the doctor gives them a prescription to some good 10 milligram hydrocodones. Those are the good ones, by the way. That's the big ones. You can actually tell when you take one of those. Of course, I'm a big guy, so it takes one of those for me to tell I even took anything. That being said, I don't have a problem with painkillers. I just know what works for me and what doesn't. So here we are stuck in this conundrum where we're trying to reduce someone's pain, which is not just physical, but at this point it's mental because they know what's going, you know, that they're struggling and what's going on. You start taking away a controlled substance that helps to reduce pain. You see where the problem is there? You know, they're going to start having other problems. So that's definitely a barrier that healthcare professionals have to deal with. Sometimes there's little financial incentive also for some of the things that need to be done to help with pain. You know, it may be something that we need to just kind of decide that we need to do for the health of our patient, and that we don't need a whole lot of, it may not be something that's reimbursable or something like that, you know, depending on what it is. Now, problems related to the patients as far as barriers, reluctance to report pain or take pain medication. Sarah, you work with the football team. I used to do the same thing. I was a trainer many years ago. Okay, you've got two types of players. You have one player that will come to the training room because they have a little hangnail on their pinky finger. And they come in there every day about something. And then what is your other type? The kind that'll damn near have a bone sticking out of their leg and won't come to the training room because they don't want to have to come to treatment at 6 o'clock in the morning, and they don't want to be pulled out of practice, and they don't want, you know, things like that. You've got two types. I've seen it myself. I'm not sure if it's still that bad, but there were definitely those two types when I was there. And the ones with the hangnails, they were ridiculous. And they were the ones that every day you'd see them come in and be like, oh, crap, what do you got today? And they were kind of like the little boy that cried wolf, you know, a little bit. When they actually got hurt, you were like, You'd have to do like x-rays or something to actually see if they had something going on because they were just there all the time. But, you know, some won't report pain because they don't want to go through the process or take pain medication that they need. Why might someone not take pain medication? Yeah, afraid that they might get hooked on it. They might have a past experience where they were hooked on it. My dad is like that with some medication, like that he doesn't have a history of being hooked on any drugs or anything, but he is reluctant to take things unless, like, he's not going to take a pain pill unless he's writhing in agony. I'm a little different. Okay, I'm making myself sound like a druggie today. I'm sorry. I'm a little different, but rather than wait until I'm writhing in agony, if I have a thing that says take one every 6 hours, especially on an acute injury where I'm not going to have to take them for a long time, I'm probably going to take one every 6 hours and try to keep from getting to that point. Some people just are anti-pills, anti-medication, unless maybe it makes them feel tough. You know, I got that done. I only took 2 pain pills. Good for you. I took 12. You know, and I didn't hurt as much as you did. You know, so that happens. Some problems related to the healthcare system. You've got inadequate reimbursement. You know, sometimes it gets lost in translation when you're dealing with Medicare, Medicaid, with a lot of our patients. You know how the government runs, guys, in general, and in a lot of ways, it's very ineffective and discombobulated at times. So you can have some inadequate reimbursement for things that should be getting paid for. And then there's restrictive regulation of controlled substances for some patients who could probably use controlled substances that would help them, but they may have a prior history or, a doctor that has given indications that they don't want them having this specific medication or this specific treatment. So that will, that's a barrier to pain management because you're being blocked. They're being blocked from receiving something that may be beneficial to them. All right, let's talk about the elderly. I can vouch for this. I'm not elderly, but I feel different now than I did when I was sitting out there. I promise, and y'all will too. Elderly experience more pain than the rest of the population. Kind of touched on this already. Older adults are less likely to seek assistance. They're kind of, you want to be self-reliant, especially as you age. A lot of people, it's that pride thing, and most of us have it. I wouldn't want somebody to have to bathe me right now. It just doesn't sound cool. My mother-in-law just had shoulder surgery on her dominant arm. She's having trouble with even like bathroom stuff, like cleaning up afterwards, if you know what I'm saying, like, because you're not used to doing that. Like, that is very much a mental pain source for her right now, because she is prideful and doesn't want to ask for help in that regard. Now, she's got a sitter that's there with her that can help with that sort of thing, but who as an adult wants to have to ask for that? Not me. Maybe Deshaun Watson. Oh, sorry, I don't know who's seen the news on him. Let's see. Also in older adults, they've got some complexities because of their health comorbidities. What's comorbidities talking about, guys? high blood pressure in conjunction with diabetes, in conjunction with arthritis. Like it's multiple things together, makes the treatment of pain more complex. That's the bottom line, because they've got multiple things going on. So you have to, okay, say someone has diabetes and they have arthritis and they have high blood pressure. You're talking about treating pain. You have to think about, now we don't prescribe medication, let's say. We don't. But in the treatment of these people, you have to think about, when I prescribe this medication, does it have any side effects like lowering of blood sugar or raising blood pressure? And then we as rec therapists have to think about, okay, they have a weak cardiovascular system, but they also have diabetes. When I'm doing these exercises with them, I really need to watch and make sure that I'm not bringing their blood sugar down too low, and that I have something that I can give them to get that back up if we have some sort of diabetic emergency. So these comorbidities are just multiple like risk factors for pain and declines in health. So less likely to receive adequate treatment. Why? Why do you think elderly are less likely to receive adequate treatment? Absolutely. You just hit what I was thinking. They don't speak up for themselves a lot of times. Not in all cases. Some of them will speak up for themselves and everybody else in the house, but a lot of them will not speak up. A lot of them may be in a state of, mental deterioration to a degree. They don't have the knowledge to really ask the proper questions and give, factual information you need. But and it can be due to the facility where they may be. Facts. Some nursing home type settings, assisted living type settings are better than others, period. I don't know how many of y'all have been in many nursing homes. There's some that I've gone in, they smell clean, they smell like Lysol, the floors are shiny, everybody's kind of doing stuff. And then I've been in some nursing homes where it smells like all the pee in the world is in the floor. And I know that is just part of what happens. There's bedpans, there's, people wearing adult briefs, there's things like that, but you can tell within 5 minutes of walking in a place, kind of the level of true care that they're getting. So that plays into it too. They're probably not getting adequate treatment and as much information. And how many of us have seen these videos of people in nursing homes getting thrown into a bed and slapped? And have y'all seen any of this stuff? I have. It's disgusting. Same thing with the developmental disability population, because they know they're not going to talk. And they do it to the ones that are nonverbal. They know they're not going to tell on them. And when they end up getting caught, they get in big, 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 big trouble. And it's usually because somebody has gotten wind, somebody blew the whistle, and they put a little camera in there that they don't know about. That's irrefutable. And that's the end of that. And I think that it is awesome when they get caught. Just saying that these are vulnerable people that don't need that. Also, consequences of inadequate pain relief are greater for older adults. So, okay, inadequate pain relief for older adults having higher consequences. What do you think how can it give them higher consequences? In what way? We talked about it's not just physical. Anything come to mind? I'm going to throw the word depression out there. A lot of elderly, they start seeing their abilities diminish. They're losing some of their self-sufficiency. You throw chronic pain in there that is kind of getting worse and worse and worse and worse. What's their mental state going to do? It's going down. That's where your consequences come in. They're not getting relief. It's going to truly affect them mentally in a strong way. Because a lot, you know, in the elderly population, you know, depression is a pretty high risk anyway. You know, they realize that they're getting older. My dad was getting like sentimental with me yesterday saying, he got the COVID shot that's got him freaked out because he don't know whether it's going, he's seen some videos that says it's going to kill him in 6 months or so. You know, there's videos saying good stuff and bad stuff. I just talk real to y'all. I'm sorry. I tell you like real, but hopefully y'all appreciate that. He got his second COVID shot yesterday, and then he promptly came home and watched this video of this guy talking for 20 minutes about how, which was great timing. I'm gonna tell you, perfect timing. Watch this 20-minute video of this old guy sitting in a chair saying, now what they've done inadvertently is they've set your body up for the next time you're exposed to the coronavirus in some form, and there's going to be mutations. Your body is going to go into full attack mode, and it's going to attack all your organs, and you're going to die, and we're probably going to have to stay away from the people that are vaccinated. And boy, he was in a bad frame of mind when he was texting me. He said, I sure did want to see these boys grow up. I'm like, dude, get up out of that ditch. Come on. Say a prayer, take a nap, take a couple shots of whiskey. I mean, do something. Let's get off of this and get back in the real world. So I had to kind of, you know, as you know, in that rec therapy mode, you know, I say sometimes we have to kind of give them a little, hey, snap out of it. I kind of gave him one of those. I'm the kid, and I was preaching to him last night. Like, I think at one point I actually said, you just need to hush and calm down. Kind of odd for the child to say that to the parent, but you know, you'd have to realize our relationship. Sorry, I'm on tangents today. When we're talking about children, recurrent pain is estimated to affect more than 25% of children and adolescents. What do you think? Something that may, I bet you 50 years ago, this number was less. Why is it higher now? Because kids are not in as good a shape as they used to be. Period. They're not. I see it with my own. They'd rather sit in there on a dang iPad than they would go out and play like a kid needs to play. Now, I make them go out and play, don't get me wrong, but some folks don't. And that's going to lead to more incidents of injuries that wouldn't have occurred, you know, that will cause pain, things like that. Something to think of is that children experience pain differently than adults, and they need to be treated in a different manner also when we're talking about trying to help improve their pain response, their reaction to pain. I've learned that my 5-year-old, when he gets hurt, oh, he throws the biggest fit. And if you give him attention, that fit will go on for 20 minutes. And if you tell him, man, you're all right, rub some dirt on it, it's over in about 20 seconds. It's all about how but you learn that different kids need different things. That's what works for mine. I'm not saying when you get in practice, if you're working with children, to tell your clients to rub dirt on it, because that probably wouldn't be a good career move. But when you have kids, I suggest using that and try it at least. Concerns about treatment for children. due to immature bodies and immune systems. So some of the things that we can do with adults may be dangerous for doing with kids. You know, different medications, different even activities. You know, you think of like STEM machines. Put in improper location on a young child could, you know, cause some unintended consequences. You know, things like that. So just know that that we have to have kid gloves is when it's, you know, when you're working with children, you kind of treat them a little differently because they are immature as far as their bodies and their immune systems. They're still building. And their immune systems suck right now because they're wearing these things all the time and breathing their own breath and not getting exposed to germs that help to strengthen their immune systems. Sorry, another tangent. I'm tired of these masks. I'm tired of everybody killing their immune systems. Do y'all know the equivalent of this thing right here, what it has to do with the coronavirus and the size of the particles? They say it's like putting up a chain link fence to keep out a mosquito. Okay, that's the size of the particle. But listen to this: the size, the squares in the chain link fence are 7-foot squares. That's the equivalent of how easily it could go through these masks we're wearing. Where they can help is if you have coronavirus and you sneeze, some of your snot and stuff gonna get caught up in here and there will be fewer particles running around freely for us to breathe. That's where it helps. That's my thoughts on masks. Sorry, I know y'all cared. Some myths in regards to children in pain. Number one, children do not experience pain. That's not a myth that I believe. I never have thought that. They do. Fear of addiction to pain medications, not really a problem with kids. Kids do what they're told. Your kid's not gonna take a pain pill because it was prescribed for a dental procedure and be like, whoa, I want to take that whole bottle. They don't work like that. That's, you know, kids are different than us. They're led, and, you know, that's not a problem. That's just a myth. Children tolerate pain better than adults. That's a myth. Children become accustomed to pain. That's a myth. They may become less, depending on how they're treated when they have pain. If they're like made fun of or made to feel bad, they may become less inclined to let you know that they are in pain, but they don't become more accustomed to it. They're not accurate reporters of pain. They're probably more accurate reporters of pain than adults are. Kids are pretty much honest. You know, what do they say? Kids, if you want something not to lie to you, it's kids, drunk people, and leggings. I think it's what I saw on like a little meme. Those are the three things that do not lie. They're going to tell you the truth, especially if you are a trusted individual and you ask them pointed, specific questions. They're going to tell you the truth. I mean, with an occasional outlier that just, you hear that liar went in on accident. They, that just kind of like to lie about things. Some kids just do that just to do it. If they can be distracted, they are not in pain. If they can be distracted, they can get over their emotional reaction to pain quicker. It may not be gone, but they will feel better because you have distracted them from just thinking about that specific pain. Another myth. If a child reports pain but does not appear to be in pain, relief is unnecessary. Not true. We still need to check. I mean, that's a situation of possible like negligence if you're in the field.
you've got a kid that comes to you and he says, man, I fell out there and I landed on my shin and I could barely walk for 10 minutes. I'm feeling better now. It's still your responsibility to document that something happened, to say have nursing or someone check it out to make sure that they're okay. And then you've covered yourself. You have actually taken care of the client and their pain source to make sure that it's nothing more serious than it needs to be. So just remember that. Just because if they don't look like they're in pain, if they tell you that something happened and if they report it, something needs to be in writing, in documentation to show that it was checked out. That's the key on that. So, some developmental considerations. Children tend to regress behaviorally when they're in pain. Fact. That's, they don't listen, they throw a fit. All of those things, pain causes that in children. Pain causes that in some adults. I'm just saying, it's just a fact. But more so in children because they don't know better as well as we do. Some children are at a disadvantage because they can't effectively self-report pain. Especially developmentally disadvantaged children, let's say, or children who don't have a lot of knowledge of the body or medical situations at all. They may not be able to explain as well as an adult could what's going on. That's true. So there's other methods of assessment that can be done: sensory reflexes, heart rate. When you're in pain, what's your heart rate usually going to do, you think? Go up. What's your blood pressure going to do? Go up. And then just behavioral observation. If you watch them, especially if they don't think you're watching them, you see a lot of things. That's when you're going to see whether they're hurt or not. You're going to see whether they keep looking at that hand or whether they walk normal around you, but then when they don't see you walking, they start limping again. These behavioral observations go a long way. Repetitive painful procedures in infants can cause altered pain perception later in life. That's just a factoid that we'll leave here. I'm not even going to go very deep into that, but what would be repetitive painful procedures in infants? Maybe someone who, a child who has some, let's say cleft palate, and they have to have multiple surgeries on their mouth and face to try to fix that. They're at a young age. They start, that's going to be painful. That's going to affect their life. And that's probably going to be really painful. So something, they could break their arm and may not report it as being a huge deal because in relation, that doesn't hurt as bad as when that happened, when they were working on my mouth. I don't know. That's the way I kind of see that. They see pains as being, if they're exposed to a lot of extreme pain at a young age, they'll see pain as being less of a big deal, kind of, which could lead to inaccurate reporting from them. So some general guidelines for pain management. There's a three-pronged approach. Identify the pain characteristics. Number one, where is it? Where is the pain? That's, we've got some assessments and things where there's a picture of a person and you say, circle on here where you hurt. Now tell me on a range of 1 to 10, 1 being no pain to 10 being excruciating, want to scream pain. Where are you on the pain level? Most people can understand that and give you that. So you're talking, and quality, what are we talking about? Things like, is it sharp pain? Is it dull? Is it aching? Does it come and go? Does it radiate? Things like that. How bad is it? That, severity comes into that maybe 1 to 10 scale. Clarify pain-related constructs. Etiology, where did it come from? Is it from a syndrome, perhaps, that is causing pain in your patient? And then I'm going to skip inferred pathophysiology because that's more syllables than I planned on covering today in one word. Determine pain-related functional impairment. Is there pain, both physical and the effects that it's having on them mentally and emotionally, impairing their functions, impairing their recreation activities, their leisure experiences, their participation patterns in what you're doing? Are they not doing the things that they can do or should do or are able to do because of pain? So you got to find that out. Once you know that, then you can start trying to manage it and move forward. So there's some non-pharmacological treatment options. Neurostimulation, like TENS units, that's, STEM machines. Who all has been hooked up to a STEM machine? Most everybody in here? Yeah. They're effective. When I go to the chiropractor, I always end up hooked up to one of those on top of everything else that happens in there. Physical techniques, massage, nerve blocks are something that most cases are kind of a short-term remedy. What's the first nerve block you think of? Anybody have one that comes to mind? More common in females than males. Epidural. That's an anesthesiological therapy nerve block. They go straight into the spine, and they block nerves so well that ladies can't even move their legs. It may take them hours before they can stand up and move. That is a strong nerve block. They go directly to the source and knock it out. They don't feel. You could come up with a knife and stab it in their leg and they wouldn't feel it. That's some pretty strong nerve blocking going on. I haven't tried it, but that's what I hear. Psychological interventions, hypnosis. Never tried that as a recreation therapist. There's studies out there about hypnosis and pain relief, and hypnosis and addiction cessation. We know that hypnosis comes in trying to solve cases, cold cases and things like that. They've solved things by hypnotizing people and drawing information. The mind is such a strong component in how our bodies react and how much pain we feel. And back to my crazy dad and his second Moderna shot. He just wasn't feeling real good today. He was feeling kind of fluey. You know why? Because he read that insert that came with it that says, there's a possibility that you may have flu-like symptoms on the day, the days following this. I could have told y'all 2 weeks ago that he would feel fluey today. Just saying. Right there. I promise you he's not fluey. It's fooey is what it is. So pharmacological approaches, which are more medication based, we want to achieve constant pain relief with minimal side effects. That sounds great in theory. The problem is in the pharmacological approach, we know that what happens with medication is you get one medication which has this side effect. And so for that side effect, you get a medication to help with that side effect, but it has a side effect. And before you know it, you're taking pills like that in the morning if you don't watch it. Just saying. So just something to think about. Analgesia is, I know how to say it, I just can't get it out. Best provided by 2 or more agents or techniques. So pain relief is better found through at least two different modes or actions to help it get better. There's some different delivery methods of drugs or pharmacological approaches, either orally, intravenously, intramuscularly, or topically, which is, Bengay or icy hot, stuff like that. There's a 3-step ladder for pain treatment. You want to go with non-opioids for mild pain. Those are your light pain pills, basically. Weak opioids for moderate or severe pain, and then strong opioids for severe pains. Opioids are the ones that people get hooked on. Opioids are the strong ones. A lot of locations, like I think maybe RedMed, some of these that have like nurse practitioners rather than physicians. I don't think they can even give opioids. I think they have to give you the non-opioid pain relief stuff, because it is, and also because those places like that, and I'm not talking bad about RedMed, I've been there before and I love them in there, but they have people that just kind of come and go. You could go to RedMed, and then you could go to the after hours clinic, and then you could go to all these different places that have nurse practitioners, and not tell them that you've been to these. I mean, before you know it, you got 5 prescriptions for hydrocodone, and there's a start of a bad, a slippery slope right there. And that's part of why it's kind of done that way. So categories of some pain relief drugs. We need to know this for a background, because when we're looking at our charts, when we're working with our patients, we need to know what we talk about if we see these things on charts and such. Acetaminophen is Tylenol. We need to know that. That's just that's your most common. NSAIDs are aspirin, Aleve, Advil. Those fit in that. Motrin is an NSAID. Acetaminophen is kind of the only one of those type that comes to the top of my head that's not a NSAID. Opioids generally have codeine. They are stronger for the most part. Adjuvants, they're best for neuropathic pain, which is generally, when I think neuropathic pain, I think about like neuropathy with diabetes, where you have pain that is sometimes as much of a strong tingling type pain than it is, what we generally think of pain. That's a different type when we're talking about neuropathic pain. These adjuvants, they're multi-purpose. They also include tricyclic antidepressants. That kind of treats the mental side of pain that we talked about. Anticonvulsants and antihistamines. Antihistamines are found to be, of course, first thing they cut down on like allergies and stuff like that. Another thing that we don't think about with antihistamines is that they actually are very calming in nature. What happens when you take Benadryl? Go to sleep. I've been known, never mind. I'm going too far today, I'm sorry. So, in recreation therapy, we have a role, and part of what we do is going to include physical activity. Seen as the best way to restore normal sensation. We find more rapid recovery of mobility, less disability, and stress reduction. by implementing physical activity that does not exacerbate or make the pain worse. Maybe even physical activity in a different area away from, like you wouldn't want to do, you know, jumping jacks right now with your, but you could still do some physical activity, which could make you feel better mentally or in general, could take some stress away, you know. You want to do at least moderate activity for 30 or more minutes a day on most days of the week. We may not be with our patients or have time set up with them most days of the week. That's where it comes into play, where when we meet with them and when we talk with them and we do an activity and debrief, we say, you know, this is something I want you to be doing on days when I'm not here. You know, you just told me you enjoyed it. I can't do this for you. I can help you, but I need you to step up and do this on some of these other days, and you're going to get into a routine and start seeing the benefits. That's where, you know, most days of the week, we have to get our patients, our clients to buy in, okay? Sometimes we have to really build up to that level. In some patients that are totally sedentary, have a lot of pain, things like that, you may have to build up to 30 minutes a day. They may not be ready for that right out of the chutes. Related research outcomes. Physical activity as pain management technique for older adults has been shown to be effective. It's also been effective as a pain management technique for children. Cognitive behavioral therapies as a pain management technique for older adults helps. That's where we're addressing the mental side of pain and talking to them about how their pain is making them feel and how it is affecting them overall. Cognitive behavioral therapies as a pain management technique for children, same deal. We talk, you know, kids will be honest with us. If we talk with them about how they're feeling due to their pain, then we can work on trying to change or improve their attitudes regarding what's going on, make them feel more confident, make them feel more positive, and that goes a long way in getting them better and getting them to a better place. We may not get them healed up, but they can leave their session with us feeling better mentally, and that's a start. Hopefully the next time they come back, they'll be ready to work and we can get them even farther. It's not something, you're not going to cure everything in one sitting. That's not how rec therapy works. All right, application to therapeutic recreation, snoozling it. Anybody ever heard of a snoozling room? Okay, funny name. It's, when we talk about pain, when you're in pain, do you, how do you feel? Like would you just be sitting there relaxed? Would you be like drawn up, tight? I get that way. You know, when you're in pain, and it's not just the area where the pain is. You get, you know, stressed and rigid and, you know, very not relaxed. I'm going to show you a quick video in a minute to finish us up of what a snoozling room is. It has to do with relaxation therapy. It's very recreation therapy related and based. Aquatic exercise has shown effective intervention in the pain management for fibromyalgia. We talked about that. Fibromyalgia is a very nondescript disorder that you can't see from the outside. People think people that have it are nuts. They think they're hypochondriacs. They're always saying they're hurting, they're tired all the time. But it's actual stuff. They see benefits from aquatic exercise. That's the best medium for them to find. So if you ever have a situation where you're working with someone who has confirmed fibromyalgia, if you have the opportunity to get them in an aquatic environment, that's the thing to do. Warm water, aquatic environment is great for them. Aromatherapy and hand massage were found to be effective in reducing pain as well. I mean, it can't hurt. It distracts you. Think about, I mean, that's just like me, you know, when my kid's hurting or something, I'll say, hey, hold your right hand up. He'll do it. Hold your left hand up. Hold them both up, and then I'll just like tickle his ribs. He'll start laughing and it's gone. I have distracted him from his pain. Same thing with someone who has some pain. If you can get them in a calming, relaxing environment with aromatherapy, hand massage, that's not something that I think of doing in recreation therapy, but it could in certain settings especially. Could be something that you can do in a one-on-one setting that would be easy to do. You could have some conversation, or you could be totally quiet, have some calming music, and I guarantee you they would report reductions in pain at the end of the session and an overall feeling of betterment. All right, we've covered that. Let me stop the share. I know we're getting close to kind of toward the end of our class time, but I do want to show you real quick this Snoozlin room. And 3 minutes and 22 seconds. I was going to show you more than this. We are going to watch more of our own classmates doing their videos, I promise you. But I wanted to finish this today, okay? Let's see if the sound works. All right, give me a minute. We're just going to keep this going until I get the sound.
Senses human beings have. Most people would say 5. Like auditory, our sense of hearing.
Y'all, I checked this before class. For those who weren't in here,
Recognize our vestibular or our movement and balance, and proprioceptive, which is our body position. All human beings need sensory stimulation in their day-to-day lives. This is how. If a child is unable to explore their environment by crawling and standing, then they will have difficulty walking.
I don't know. See, I didn't do anything right then. I did the same thing 10 times. This is crazy. Yep.
If you ask anyone on the street how many senses human beings have, most people would say 5, but there are actually 7. Everyone knows the 5 usual suspects. Visual, which is our sense of sight. Auditory, our sense of hearing. Olfactory, the sense of smell. Tactile, the sense of touch. And gustatory, the sense of taste. But the other 2 senses that most people do not recognize are our vestibular, or our movement and balance, and proprioceptive, which is our body position. All human beings need sensory stimulation in their day-to-day lives. This is how we learn and develop. If a child is unable to explore their environment by crawling and standing, then they will have difficulty walking. For individuals with intellectual and developmental disabilities, there may be difficulties in processing everyday sensory stimulation from both the outside world and from within their own bodies. For this reason, NHS Woodhaven has created a sensory room to assist their individuals to help improve their sensory processing. Using various pieces of sensory equipment, we can help to improve everyday activities, problems.
I'd like hanging out in that room.
Motor skills or behavior problems. The auditory system, or our sense of hearing, helps individuals learn, benefit from social contact, communicate, and orient to their environment. For this sense, various music and sound effects can be used to both stimulate and calm a person. The olfactory system, or our sense of smell, can evoke memories, give information about the environment so that you can identify things around you, and helps taste food that you are eating. For this, aromatherapy bottles can be used to introduce scents to a person. Scents like peppermint can stimulate a person, while scents like lavender can be calming. The gustatory system, or sense of taste, can detect flavors of substances. Due to dietary restrictions, this is something that is addressed on the residential units rather than within the sensory room.
Plus, they don't want to have to clean up the sensory
The
room.
visual system, or sense of sight, helps us to know where we are in space and to sense when we are moving. There are various pieces of equipment that can be used for this, such as the disc projector and the star ceiling. The tactile system, or the sense of touch, helps to send sensory messages that are received through the skin to the brain. Information received through touching allows us to learn about the different qualities of an object, such as if it is hard or soft, cold or furry. Some of the equipment that can be used for this includes the bubble column and various handheld pieces. The vestibular system senses movement, and its sensors are within the inner ear. Our ability to balance.
You think that fella likes that room?
relies on the vestibular system. Experiencing movement can improve balance and postural control. The water bed and the rocker can be used for this sense. Proprioception refers to sensory information that comes from the body itself. This includes muscles and joints. This input tells us where our bodies are in relation to the environment. It also helps us know where our arms, legs, and body are when they move them. For this sense, we can use the fiber optic waterfall and weighted blankets.
All right, who thought that was interesting? I'm gonna tell you, if I was opening up say I was gonna leave tomorrow and I was gonna open up a recreation therapy center, you know, a service, I would put one of these rooms in, and I would make it known that I could help people who had sensory issues in 7 different routes, you know, that they talked about there. It's pretty, they have groups out there, you know, just like they build adaptive playgrounds and things like that, they will come in and build you a snoozling room at your facility. They have all these water tubes, and I mean, you could go lower budget and get you some lava lamps and things like that. I mean, we have to adjust sometimes according to where we are, what we can work with. I'm going to stop there for today. I was going to show y'all a couple of yourselves in action from the videos, but we ran out of time. But the good thing is we got chapter 14 covered. Now, this is either good news or bad news that I'm about to share with you now. In approximately 3 minutes, test number 2 will become available on Blackboard, and it will be available through, if I recall correctly, April 5th. So that is a long time. You do not have to sit, you don't have to finish it in one sitting. Like, I didn't mark that on the thing, so y'all can start and work at it. It's just the same as the take-home test like we had before. It's just on Blackboard. So, and that way I won't have to hand hold each one of them and grade them like I did last time. So it's better for everybody. So it's going to open up today, open through April 5th. That's where we're going to go next. Class, let's see, y'all are bringing me your hypothetical case study number 2 to turn that in on Tuesday. And honestly, even though we're about to take, you know, this test is opening up, we're probably going to jump right into another chapter or spend the majority of the class. Maybe that class might be spent on watching more of y'all's videos. We'll see. I'll decide between now and then. Y'all have a good rest of the week and a good weekend.